the all-party group on coronavirus, and the focus of today's session is on long COVID and getting an update on where we are at on the issues of long COVID. We have two panels. My name is Caroline Lucas, and I'm going to be chairing part of the first session until our permanent normal chair, Leila Moran, comes back from the chamber where she's inevitably detained just for a few moments. So in this first panel, we are absolutely delighted to be joined by two experts, Dr. Benita Kane and Dr. Ray Duncan. And I'm going to hand over to each of them in turn to briefly introduce themselves. So to Benita, first of all.
Thank you, Caroline. I'm Dr. Benita Kane. I'm a consultant respiratory physician in Manchester. I've got a special interest in long COVID, and I treat long COVID patients in the NHS, as well as leading some research.
Wonderful, thank you so much. And to Ray Duncan.
So my name is Dr. Ray Duncan. I am a consultant cardiologist and laterally long COVID research clinician. I also treat long COVID patients in the NHS, particularly with an interest in the cardiovascular side of long COVID. I'm also involved in heading up some UK research into long COVID, and along with Benita, I sit on the expert advisory team for long COVID for the World Health Network.
Brilliant. Well, you're both incredibly welcome, and thank you so much for making time in what I know must be an incredibly hectic schedule that you both have. And I guess my first question was just a very broad question to bring us all onto the same page, which is around what are the main challenges faced by long COVID patients in terms of accessing comprehensive care right now?
Yes, so I may take that, and Caroline, I have put a few slides together because I think this is quite a complex issue actually, and I think it would be useful just to sort of show a couple of schematics, just try and really capture what it is that we're trying to get across today. So if I may just share my screen, which I hope will work. And what I wanted to do, can you all see that?
Yes, that's great.
Yeah, what I wanted to do first of all is really just bring this back to the patients. We know that long COVID is an extremely disabling condition affecting a couple of million people in the UK, of which 66,000 of them are children. This is how children with long COVID describe their lives. This is from the charity Long COVID Kids. And it's really heartbreaking when you look at some of those words: rubbish, broken, ugly, lonely. And Rosie Pigeon is a really talented young artist who has long COVID. And I just think this graphic from her is really powerful. This is how people with long COVID feel. They feel not seen and not heard. And the work that this group is doing is really, really important. COVID is, part of the challenges that we have is that COVID is a really, really complex condition that affects every single body organ. So this shows all the different symptoms that are listed under the various different body organs, from the heart to the head and neck to the immune system, the skin, the reproductive organs, the stomach, the gastro system, pulmonary system, and the brain. And you can see that there's between 19 and 80 symptoms listed under each of these. This is complex medicine. And as a chest physician, I have immersed myself in the research over the last couple of years, tried to learn everything I can. I've had to relearn huge swathes of medicine, but also medicine I was never taught, because although post-viral illnesses are not new, they've been around for decades, we as healthcare professionals are not taught about the underlying pathology, how to manage this. And the way that we are set up as single organ specialists, like Ray being a cardiologist, me being a lung specialist, is not geared up to managing this. So suddenly, when there's 2 million people who are struggling with a multi-system chronic problems, it's a massive challenge for the NHS, which is already overstretched post-pandemic. So I'm going to take you to how the post-COVID services currently work. And first thing to say is that these were set up in 2020 at a time where the UK was really leading. No other country was really looking at post-COVID conditions, and the scale and pace at which this was set up was really admirable and done on the best information we had at the time. But having said that, 3 years on, things have moved on quite significantly. There's over 300,000 research papers now about COVID. And the NHS, being the juggernaut that it is, isn't agile enough to sort of keep up with those changes. And the lack of research as well means that we've got a gap between the science and that, you know, being converted into actual meaningful treatments for patients. So just looking at the current pathways, which we're still using in 2023, there's a whole part that happens in primary care from when the patient has been unwell for, say, over 4 weeks, persistent symptoms. That includes an assessment by the GP, excluding other things, which is really important because there's lots of overlap with other conditions. And then the options are various referrals, so mental health support, referring to specialists if needed, paediatric services. The patient's then encouraged to self-manage through the Your COVID Recovery platform and access community therapy and support. If they then need further ongoing treatment, their symptoms have been going on for 3 months or more, they're encouraged to be referred into the post-COVID triage and assessment services, where the options for management are generally self-management once you've had the detailed assessment, referral into a post-COVID rehab service, which consists of physical therapy, psychological therapy, and psychiatric therapy, or referral into single organ specialist clinics. So if you've got a heart problem, you go to heart, lung, gastro. So what that does mean, though, is for the individual patient, things can end up being quite disjointed, and there is a lot of waiting. So this is an example. This is not meant to represent everyone's experience, but an example of what might happen to a patient. And this is based on what patients have told us. And our, we are linked with lots of long COVID charities, and we treat patients ourselves. This period between the GP referral and the assessment in the long COVID hub, bearing in mind the patient's already had symptoms of 3 months, can take a long time. And there's a lot of variability across the country. That could be anywhere from 3 months to a year. And in some paediatric services, I think it's even longer. When you're finally seen in the long COVID hub, you may or may not see somebody who has a detailed understanding of the condition and who's been trained in the condition. Often it's quite tick box assessment. Sometimes it's done over the telephone, which means you'd lack that all important clinical examination. And often at this stage, the clinicians involved are not empowered to actually treat. Even if you find something you can treat, they're encouraged to refer on. Patient might then be referred directly into rehab, or they might be referred into a specialist meeting where lots of clever consultants from different specialties get together to discuss the patient, and the patient waits. At this point, they're generally referred for more tests. They might have a heart problem, refer for heart tests. They might have a lung problem, refer for lung tests. And it's important to say that most of these specialists have never met the patient or assessed the patient. Sometimes they've only ever been assessed over telephone. The patient might be referred to other specialties at this point, and they wait. Sometimes there's 3-4 month waits for those appointments. They then wait for their tests. They then have their tests, and they wait. And then they wait for their results. And then they wait for their follow-up appointment. And at the end of all of that, they're often told, your heart tests are normal, your lung tests are normal. We're going to discharge you from our clinic. They may or may not get any treatment. So they go through this entire process for maybe 12, 18 months. And at the end of it, may still not have treatment, may still be very, very unwell. So what generally happens is, from all the referrals, patients fall into three buckets at the end of it. One is they don't have long COVID, and that's important because of this overlap with other conditions. They have lots of tests, and actually we diagnose them with thyroid disease or something else, and they get appropriately referred on. A proportion of patients absolutely improve with symptom management and with the rehab, the rehab services that are out there, and they gradually improve over a year to 2 years. They may not be back to baseline, but they can get back to living a life. But there is a large proportion of people who we estimate about 50% who are stuck, who have been through this whole process and are still no better, are still very debilitated, cannot work. And And what we are doing with them, they're often stuck between lots of different clinics, no one coordinating their care, and struggling. And I think really important point here is that managing symptoms is not the same as treatment of the underlying condition. In the same way that I wouldn't treat somebody with diabetes just for their symptoms, I would want to treat the underlying disorder of blood sugar regulation. And the same principle should apply here. So my final slide is really thinking about what changes are needed to the model. Well, what we definitely do have, and we've done really well, is that we've got caring clinicians who are seeing patients, supporting them. And we've got access to lots of assessments and tests. We will argue that we don't have access to all the right tests. We're good at providing therapy-based approaches and psychological support. We are good at referring into single organ specialty clinics, but we have poor access to treatments and to research studies. Now, what patients want and need, actually, when you talk to them, they're very grateful for everything that the NHS clinics are doing, and we are not taking away from that at all, but they want to see someone early who really understands long COVID, the whole body, not just a specific organ. They do want the right diagnostics that we know are available in other countries and will help us get to the bottom of the underlying problem. They want holistic care from one team and care coordination rather than being split amongst several different clinics, with specialist advice from external teams. But we have many specialised commission services that are set up in this way. Holistic care from one team, bringing the expertise in from outside if needed. They need a lot of ongoing mentorship and support, which is absolutely where the rehab services come in, and the physical rehab when they are well enough. So that was all I was going to say on that, but I hope that gives us an idea of what the void is. The void is in the funding and the investment, the workforce, the skills, the training, the education in the illness, and in long COVID and post-viral illnesses like ME/CFS. The trials, desperate need for treatment guidelines, and we want better equitable access to care.
Thank you so much. The scale of what you've just set out, I think, leaves us in no doubt about the complexity of what we're talking about. In terms of asking a few follow-ups, I think I was going to come to Debbie Abrahams next.
Thank you so much. That was so interesting, Benita. Thank you. I also am involved in another group, and I was just which is the APPG on ME/CFS, and we actually were discussing the similarities with a clinician from Exeter, whose name has escaped me. But many of the things that you have described in terms of the issues that ME/CFS patients have faced in terms of therapies, that they will have normal range tests, including blood sugar. I just wondered what opportunities and learning that there may be from clinicians that also have been working in this field. And I'm conscious that there are a number of trials that are underway, and I wondered what we could learn from them.
Yeah, there's absolutely huge overlaps between ME/CFS and long COVID, and I think there are definitely some unique things about long COVID, but huge overlaps. Definitely in terms of the patient experience, in terms of the research, in terms of the normal tests, and not having access to the right tests and diagnosis is common across both. And hopefully Ray, when she comes on to talk about this, can expand a little bit on that as well. So we should cover that with some of what Dr. Duncan's going to say.
Well, at that stage, Ray, do you want to come in? I don't know if...
So do you want me to talk about question 4 now, or are we moving on to that, or?
Why don't we just hang on for a moment, actually, otherwise we'll lose the progression of the questions. I know that some of the questions that we had, in a way, Benita, thanks to your very clear and comprehensive diagrams, have been addressed to some extent. But if I can maybe just bring us to question 3 for a moment, before we do 4. And that was about in a sense, in what you've set out in those slides, it demonstrated just the huge number of different specialisms that are involved, whether that's respiratory specialists or physiotherapists or occupational therapists and so on and so forth. And my question really was, how can we coordinate between all of those? I mean, I appreciate what you were saying about having a core team and then bringing in external ones, but how does that actually get managed on the ground?
I mean, I think we've got really good examples, Caroline, of where we're doing this already. So as a respiratory physician, I've been quite heavily involved in severe asthma services, for example, where we've got, you know, a specialist centre, a core team of consultants, and all of the therapists work very closely with us to deliver the specialist treatments. And we have those MDT discussions where we bring in the allergy and the ENT, but it's a core team that coordinates the care and coordinates that overall pathway. So there is room for all of those specialists. At the moment, I think the problem is it's quite disjointed, and and they're not necessarily working with one specific consultant with expertise in long COVID. They're working with lots of different people, or not at all. They're sitting separately in a rehab service. So I think this boils down to the fact that we need more dedicated services for long COVID that are overseen by a specialist in the field, but we need to train people to become specialists. I think that's another big problem, that we don't have the expertise because of the
would that take?
It will take a while, but you know what? If we don't start, we never finish. And I think that's the key, is that we need to get onto this path of that upscaling and that education about these post-viral illnesses, and particularly ME/CFS as well.
Okay. Let me come back to Debbie to put question 4, I think, to Ray.
Okay, if we're sticking rigidly to the briefing, then that's fine. So, can long COVID clinics effectively manage the wide range of symptoms experienced by long COVID patients, and what interventions are currently most effective in treating these symptoms?
So I'm going to come to that, but I'd like to do it the same way Benita has, if it's okay with yourself, just with a couple of slides.
Yeah.
Because I think it's important that the panel and the people listening to this understand what long COVID actually is, because without understanding that, we can't answer the question. Can you see my screen?
Yeah.
Okay, so really, the first part of the question, I'll take the first part of the question first, and it's a really interesting question, because long COVID is kind of an umbrella term for quite a heterogeneous condition, of which there is over 200 recognised symptoms, 200 across all body organs. So if all we are trying to do in our long COVID clinics is to manage the patient's symptoms without trying to understand the underlying cause of the symptoms, and without trying to treat the underlying cause of the symptoms, then we are setting ourselves up to fail, and we're going to fail our patients. And we're also setting up our NHS services to fail, because we need to understand the underlying pathophysiology, and that's the medical term for the disease process that's going on inside the body after COVID infection and what the virus is triggering. Now, at the beginning of the pandemic, as Benita has said, we didn't know what the underlying pathophysiology was, and so symptom management actually has been very helpful, because it's stopping people getting worse. It was allowing a certain group of the people to rest and pace, and giving them a chance for their bodies to heal themselves. But we now know there is a significant group where the bodies isn't able to heal themselves, and what we really need to concentrate on now is the actual treatment. And I think to do that, we need to understand what is going on. We're in a very different position now than we were 3 years ago. We can no longer say as doctors that we don't have any understanding of the underlying disease process, because we do. There's thousands of publications now. We may not fully understand all of it, but we understand enough that we can be starting to treat some things with certain therapies we already have, while we're still researching the therapies that we don't. And what I'd like to do, if it's okay, just for a couple of minutes, is just for the purposes of people listening, is just to explain a little bit about what we now believe long COVID actually is, because a lot of people listening to this will not know. They will assume it's post-viral fatigue, or people just feeling tired, or they just need to have a rest. And it's not any of these things. So, excuse me. And the other thing that's important to know is long COVID is one spectrum of COVID itself. It's a disease spectrum, and it's not binary. It's not you either have COVID and you fully recover, or you have COVID and you get long COVID. There is now emerging research suggesting that even those who've been infected and don't have persistent symptoms of SARS-CoV-2 may still have some underlying organ damage that is silent. And that in itself is quite concerning. And obviously we need to do more research into this. But this is where we're up to. So how do we find a unifying diagnosis that would explain over 200 symptoms across multi-bodily systems? To understand that, we need to understand the pathophysiology. Some of the damage is directly virally mediated, we believe. Some of the damage is the host immune response, as it's trying to fight the virus, is damaging some of the organs due to inflammatory responses. Some of it is triggering clotting abnormalities. Some of it may be due to viral persistence in individuals that can't clear it. We don't know that for certain yet. There's a lot of work going on in the States with Amy Prohl's group looking at that. And in others, there may be some evidence of autoimmunity. But what we do know is that when SARS-CoV-2 it infects us, it's not just a respiratory virus, and it is certainly not just a cold. It enters through the respiratory tract. It infects lots of different cell types through the ACE2 receptors. But what's happening in the bloodstream is when the immune cells which fight infection come in contact with the virus, we're getting the virus triggering an aberrant innate immune response. So we're getting things like non-classical monocytes. We're then getting chronically stimulated T cells. And what they're doing is they're chucking out loads of molecules called cytokines that are pro-inflammatory. And what these are doing is damaging the inner lining and inflaming the inner lining of our blood vessels. Now, in turn, what that then does is that triggers another host response where platelets, which are the molecules involved in blood clotting, see that the endothelium's damaged, think it might be a cut, and so they then trigger this clotting response, and it triggers the clotting pathways. And so we end up with a situation where our blood becomes more thick and sticky and more prone to clotting. Now, after acute COVID infection, in some individuals, they may go on to develop big blood clots. If those blood clots happen in the coronary arteries, they have a heart attack. If they happen in the cerebral arteries, they have a stroke. If they happen in the pulmonary arteries, they get a blood clot on the lungs. These can be life-threatening and life-changing. You don't necessarily need to have long COVID to be at risk of this. You just need to have been infected. But in long COVID, the clots are different. They're very tiny fibrin amyloid microclots. They're not normal clots either. In the presence of spike protein, the fibrin molecule, which is involved in clotting, becomes misfolded into this amyloid formation. Now, we're very lucky we have the world leading expert on this in the next session, which is Professor Pretorius, so I'm not going to talk too much about this. But we can make thousands, and we're seeing thousands and thousands of these little clots under immunofluorescent microscopy in individuals who've developed long COVID. And what we think may be happening in the capillary vascular beds, which are the really tiny blood vessels, those blood vessels are not nearly as well protected as the bigger blood vessels because they don't have the protective muscular coating. And if they're becoming inflamed and these little vessels are getting narrowed and then the clots are getting stuck in them, that is potentially reducing the oxygen flow to every single organ in our body. And that may be responsible for at least some of the symptoms that we're seeing with long COVID in different organs. And one of the things that we can do a mixed venous peripheral oxygen saturation blood test. And we're seeing quite a lot in long COVID patients, and I check it in all of my patients in my clinic, that these are abnormally low, suggesting there is a problem with oxygen delivery to the tissues. And the other thing that this may be doing, and there is some data I can't obviously talk about all the data in the time frame we've got, but I have got all the papers, I can send you them all, but there is published data supporting everything that we're talking about. Is that at a cellular level, the mitochondria in the cells, they're the ones that are responsible for producing the energy molecules. Now, that requires oxygen. To produce the right amount of energy in the cells to allow them to function properly, you need oxygen molecules. If you don't have enough oxygen, the amount of energy your mitochondria will produce will be a third of normal. And this is an energy sapping illness. And there is some evidence to suggest that it may be reducing issues in the mitochondria as well. So we need to understand all of that if we ever want to be able to treat this condition properly. And what I want to just show you here is this is what's happening in the body. These are hyperactivated platelets in somebody with long COVID. Can you see they're big and angry looking in purple? This is what they should look like. These are what microclots look like. And this is a normal control that has almost hardly any. I think there's 1, 2 tiny little ones there. And what we're seeing here, these are shards of endothelium that have, because the endothelium has become so inflamed, it's ripped off and it's floating around in the bloodstream of our long COVID patients. This is from an adult. This is the endothelial shard of an 11-year-old child that is now in a wheelchair after COVID. And this hip CT scan here is demonstrating that in the lungs, these are not air sacs, these are blood vessels in the lungs that have become damaged. And so it's really important that we do understand this. It's causing endothelial damage, and this is important as well from my perspective as a cardiologist, because we know that endothelial damage not only we believe is involved in the development of long COVID, along with obviously inflammation of other cells and direct viral invasion, but we've known for many years that endothelial damage is also involved in the development of cardiovascular disease. And there are now multiple publications across multiple continents looking at millions of patients, all showing the same thing, that as well as long COVID, there is a significant risk of cardiovascular and neurovascular disease after COVID infection. And one of the issues that we've got is if all we're trying to do is manage symptoms and we don't understand the underlying problem, if we won't do the right tests. There are tests that we now have that can be helpful. At the beginning, we were doing all our standard tests, we're coming back normal, but there are tests that we can do that can be helpful. And if we don't do the right tests, we'll not get the right answers. If we don't get the right answers, patients don't get the right diagnosis, then they won't get the right treatment, and then they won't get better. We have now got, according to the IHME, 145 million people in this country, globally, suffering with long COVID. 22 million have had it for more than a year. And it's costing the global economy between COVID and long COVID an estimated $21 trillion. So really, we do need to be looking at this in lots of different ways, and we really do need to be prioritizing it. And where we were at the beginning was we were getting the diagnosis and we're sending the patient straight to rehab. But as part of that rehab, we were doing very sensible things like teaching them how to rest, teaching them how to pace, teaching them spoon theory. And that's great for self-management of symptoms. But now, as we've learned more about the condition, what we need to be doing is adding in this middle section, which is diagnosis, treatment, then rehab. So just as an example, for example, if somebody had an acutely inflamed knee or a broken leg, you would never dream of sending them for rehab until you treated the inflammation and let the knee heal, and then you would rehab them. So in the same way, we need to be identifying these subgroups of patients who have an acutely inflamed blood vessels, because you can't rehab them until you've treated the inflammation or the underlying damage if you want them to get better properly. And so there are different subgroups, we believe. There are some that seem to have histamine issues that can respond very well to antihistamines. There are subgroups that have clearly got endothelial abnormalities, and I check all of that in my clinic now. I'm not sure many other clinics do, but I've managed to get access to some of these tests, and quite often that they're not normal. And then there is another big subgroup that we could be treating, which has got dysautonomia. Now, our autonomic nervous systems are the nerves that control our unconscious bodily functions. So heart rate control, blood pressure control, temperature regulation, bowel, bladder, gut, sleep cycle. All of that can be disrupted by COVID, and we know from the published research that the most common disruption we're seeing tends to be around heart rate and blood vessels, which is where we as cardiologists quite often get involved. And again, depending on the paper that you read, between 38 to around 50% of individuals may have a condition called postural orthostatic tachycardia syndrome, post-COVID dysautonomia, where they cannot control their heart rates properly when they stand up. And it can be incredibly disabling to the point some people cannot walk. Now, if we have 2 million people in the UK and with long COVID, and we are not routinely screening for this, which we aren't in all of the clinics, we are in some now, that means we may have up to 1 million people with undiagnosed POTS syndrome, that are not being treated, that could be being treated because we have got treatments for it. And it can be very disabling. And I have examples of in my clinic of patients that have seen 3 or 4 different doctors, and then they've come to me. I had one girl in particular who's given me permission to talk about her anonymously, who had such horrific POTS she could not stand. And she'd listened to one of the international educational talks Benita and I had been involved in. She'd recognised the symptoms. She'd gone to her doctor and said, I think I've got this. And she'd got really sick and been admitted to hospital. She'd asked for them to do a nasoline test, which we were talking about. It was done. Her heart rate shot up to 200. She almost fainted. And instead of being told she had POTS, which was clearly a diagnosis, she was told that it was suggested that she developed a psychological fear of standing, and she was referred for cognitive behavioural therapy. At which point she went to her GP and begged a referral to me, and I've taken her on. And she was at the point she'd almost lost her job. She'd been unable to walk for a year. And within 6 weeks, she's now back on a graded return to work on medication. So some of this is treatable, but we need to know what we're treating.
I can just do some follow-ups, Caroline, is that all right?
Yes, of course.
Absolutely outstanding. Both of you, you've been so informative. Now, you're obviously incredibly sensitive and thoughtful physicians, and that's absolutely what's needed in terms of the diagnosis of the different, as you say, the probably will be a classification ultimately of COVID in terms of the different underlying conditions that people develop as a result of infection. But you both mentioned different things. First of all, Benita, you mentioned in terms of treatment guidelines. I know colleagues that have had long COVID who've been put on the same discredited treatment guidelines that MECFS was, so prior to the new ones. So in terms of consistent application, the approaches that you're advocating for, when can we expect to get those? I'll park that to one side. The other thing that you mentioned, Ray, is in terms of diagnosis. So, and Benita had also said earlier, in terms of some of the tests that were undertaken showed people to be within the normal range, whether that was blood sugar and so on. So how can we make sure that we have a standard battery of tests that can help in the diagnosis of these different conditions? And the final thing that you mentioned, Ray, was in terms of the economic impact of this. If we are, and Caroline, Layla and I have been working on this for a long time, to get this into the government's agenda, it is about, unfortunately, it's about the economics. We heard today, and I was recently in the States and asked these questions around economic inactivity, but also people who were economically active but unable to work currently because of, so in other words, they're needing social security support for being out of work because due to ill health. These are issues for all major industrialized economies. So to have an understanding of the impact of that in terms of the economic impact is very, very helpful. And then to make sure that we have appropriate responses and not forcing people back to work and potentially making it even worse for them. So I know I've thrown a lot at you there, but if you could respond, that would be very helpful.
So Debbie, if Benny, if you're happy with this, I'm going to come into some of that. So to talk about the economic impact, I preempted you were going to bring this question up. So I'm not an economist. So obviously I've taken expertise from the experts. And what I did before coming on here is I contacted Professor Luke Vale, who is a leading UK health economist for the United Kingdom. And I asked him to get together with his colleagues and do me some economic modelling, because I am convinced that our current let it rip policy of allowing people to get infected and reinfected, especially because Dr. Tedros, from the Director General of the WHO, has made it very clear that 1 in 10 infections, not 1 in 10 people, 1 in 10 infections results in long COVID. And we're already looking after patients who are on infection number 4 and 5. And they are predicting that hundreds of millions are going to require longer term care. This is not sustainable, either from a health perspective, from a humanitarian perspective, or from an economic perspective. So if we look at at the world globally, what do we know? We know from the Global Preparedness Monitoring Board, that, from the World Economic Health Forum, that COVID has already cost the global economy $11 trillion, and it's predicted to cost another 10 trillion going forward in workplace absence. A lot of that is largely long COVID. From the US, there's economic modelling data that's come out from Professor David Cutler from Harvard, and he's done economic modelling for the United States, suggesting that it's going to cost the US economy $3.7 trillion. And Professor Luke Vale's team have done some very simple economic modelling for us for today's meeting. And they have suggested that given what we're seeing at the level we have at the moment, it's going to be costing around 60 million per annum.
I'm going to have to speed you up just a little bit.
Yeah.
I'm just mindful that we're just beginning to eat into the time for the next panel.
Sure. So around 60 to 61 million per annum. Now, that's obviously assuming lots more people don't go on to develop long COVID, but there's a chance they might, because people are getting reinfected and reinfected and reinfected. With regards to asking about testing that we can do, I mean, my clinic is set up a little bit differently because it's a cardiac clinic that sees patients with cardiovascular symptoms, predominantly chest pain and palpitations after COVID. But things that I have found helpful is all of my patients, I see a lot of very ill ones that can't come in and sit in an outpatient clinic. So I do a virtual Zoom clinic with them first so they can seek help from their beds for patients that are bedbound. Once I've worked out what I think is going on, then we try and bring them in and do a one-stop shop. And we do it on our day case unit so that the patients are able to lie down in between the tests. Each one has a nasoline test or an active stand test to diagnose whether or not they have POTS syndrome or evidence of dysautonomia. And if they do, they get treatment, both non-pharmacological and drug treatment. We know the virus is thrombogenic. We know that the clots in the lungs may be in a different distribution to your average blood clots. There can be more kind of peripheral and smaller. And we know that through work we've been doing with our international research group, including long COVID radiologists. So they all get a sit to stand oxygen test. Looking for oxygen desaturation, they all get a D-dimer, they all get a mixed peripheral venous oxygen saturation, and if there's a suggestion that there may be any missed blood clots, then they go on and get specialist scans, and that can be a VQ scan or a CT DEC scan, and there is reasons for choosing those because they can show up more peripheral perfusion defects. We are seeing in some people...
And how common are you, Benita, as well?
Yeah, so I think I've just got 2 points to make on what you've said, Debbie. I think the first is about the rehab and the treatment that was previously promoted for ME, CFS, which was graded exercise therapy and CBT type approaches. Now, graded exercise therapy has been found to be harmful in patients because actually, if you're driving the car with an empty petrol tank because you can't get oxygen into the tissues, driving and revving the tank harder is just going to cause damage. And so that is now been taken out of all the NICE guidelines. And the biggest problem we have is culture change, because I think these ways of practicing are very deeply ingrained into our clinics and into the rehab services, and the education isn't there about the physiology. So people don't understand in all other spheres of our life, exercise is good. I think the second thing I would say about the tests, Debbie, is that sometimes tests are being done and they're not being interpreted properly. So a 24-hour heart rate monitor, because there's no rhythm disturbance, is being reported as normal, but actually someone laying in bed with a heart rate of 120 doing nothing is not normal. And so they're not being interpreted in the context of the patient and the patient's symptoms. So again, that just goes down to it being a personalised approach and having a specialist who can interpret the tests in the right context as well.
Brilliant. Thank you so much, both of you. I found this absolutely fascinating. And if we could have copies of the slides, we're doing an inquiry on this about economic inactivity affected by long COVID. So it would be really, really helpful to feed that into the committee, the select committee. Thank you.
Thank you so much. That was really, really excellent and very comprehensive. Layla is now back with us, taking over the chair, and I think she's probably going to come to Paul.
Indeed.
Hello. I'll go ahead. Good afternoon, and thank you very much, both of you. Your evidence has been quite alarming. both in terms of the scale of the problem and the implications for those who are suffering from it. And also your theme that there's too much focus on symptoms rather than causes, and that best practice is being successful, but is not being used in a widespread way. And most of all, the theme I've picked up from you is that if this was an orchestra, it'd be an orchestra without a conductor, lots of talented musicians, but no one's calling the shots. So my question to you is, what would be your key recommendations to the government? You'd like to go first, Benita?
Actually,
yeah. So Ray and I have put something together for this actually. So do you want to do that this bit, Ray?
If that's okay, but if I could beg your tolerance for a couple of minutes there before I make the key recommendations. There is one other area that we haven't covered yet that I would like to, with permission, just have 2 minutes to speak about. Would that be okay? And it's about prevention. Right. Because if we really want to tackle long COVID, we have to stop people getting long COVID. And I think really what we need to look at is really we need to take a step back and we need to look at the bigger picture here. And again, if we can just go back to the WHO for a second, very clearly Tedros has stated 1 in 10 infections results in the post-COVID condition, suggesting hundreds of millions are going to become disabled, requiring longer term care. And Maria Vankakova has very clearly stated that because partly maybe because we've allowed this virus to spread so freely, it's mutating, it's developing immune escape. And if you've been previously infected, you are not immune. If you've been previously vaccinated, you are not immune and you can still get reinfected. And certainly in my clinic, I'm seeing patients that have been infected 3 or 4 times. We have published data that vaccination doesn't prevent long COVID. It only reduces the risk by about 15%, depending on the study you use. And we also have published data that show, and I'm showing it here on my slide, that each reinfection cumulatively increases your risk of long COVID and cardiovascular disease and neurological complications. One of the issues is despite knowing all of this, we seem to have taken away mitigations. We seem to have reduced boosters. We're allowing this virus to spread freely, and I'm not entirely sure why we're doing that. And I wonder if part of it's because those who are making policy decisions are doing it, and they're basing their decisions on statistics and figures and numbers, whereas we, the clinicians, what we're seeing is not the statistics and the figures and the numbers. We are seeing patients and people and lives, and the COVID statistics are not capturing the horrific degree of disability that we are seeing in our clinical practice. I'm sorry, I always get emotional when I talk about this, but about 50% of the patients to my clinic, I'm just going to use my clinic as an example, are now long COVID referrals. Generally, they're young adults, aged 16 to 40, previously fit and healthy, with no pre-existing health conditions. Many of my patients are now housebound. Some of them are bedridden completely. Some cannot walk, others in wheelchairs, some cannot even stand up. Some of my patients are spending 20 to 23 hours a day in bed and are only able to sit upright for 15 to 20 minutes at a time due to severe orthostatic intolerance, because the virus has damaged their autonomic nervous systems and they can no longer control their heart rates. And they're not recovering in a year, nowhere near it. And that's because of the reinfection rate, I think. I've seen so many patients, they've had COVID, they've done okay, they've caught it a second time, they've developed long COVID, they've struggled to get better, they have improved, they have managed to get back to work, they've caught it a third time, and now they're bedbound, housebound, unable to stand. None of these patients were hospitalized during their acute infections. So in the COVID statistics, they are coded as mild COVID. There is nothing mild about caring for a teenager who's now unable to walk. There is nothing mild about a 26-year-old former athlete who cannot stand up. There is nothing mild about a 34-year-old young man who's had a heart attack. And there's nothing mild about the 38-year-old mother of two who is bedridden and cannot care for her children. And her 2-year-old and 4-year-old don't understand why mummy can't play with them anymore. There is nothing mild about these patients who've lost their health, their jobs, their livelihoods, and some of them are now losing their homes. There's nothing mild about any of this.
Paul, I'll maybe come in and just pick up the last point, because I can see Ray's quite emotional. I mean, it is emotional talking about our patients, actually. I think our recommendations for the government are sort of sixfold, really. We need better public health messaging, because the public is not aware of the damage that COVID is doing. We need to, so acknowledge and educate. This is our final slide. Acknowledge and educate. That's for the healthcare professionals, but also the public. We need to prevent, and that is through mitigations like ventilation and clean air, which is, in terms of the return for the investment we'll get, is a complete no-brainer. So clean air in schools and hospitals is a minimum, but actually in all public spaces. We need to protect patients from reinfection as well. We need to teach people how to manage their own risks. We need the funding in research. We need the funding for the NHS to match the scale of the problem and the cost to the healthcare economy. And most importantly, we need to start treating patients. We know how sick these patients are. And if we can do that, and we believe all of this is possible, we can learn to live with COVID as safely as possible.
Thank you. Thank you. I mean, it's nothing short of a national scandal.
Thank you, Paul. Thank you, Benita. Thank you, Ray. That's the, I think you bring it right back, Ray, to the patient and the individuals and the lives that have been so awfully taken away, and shown us that actually for many of these lives, it could be different if there were a different approach. Is very much in line with what we're trying to do as an all-party group. So can I thank you sincerely both for this incredibly informative, and in our private WhatsApp group, some of us are writing terrifying because it is terrifying, both the scale, but also it's a terrifying prospect that the government's going to miss the opportunity, which is what we're trying to avoid. So I thank you very much, both of you, especially Benita, who leaves us at this point. Ray is going to stay on for panel 2, where we are going to now look at where some of the research is. So as they join, I will go ahead and start to briefly introduce them. So joining us for panel 2, we have Dr. Caroline Dalton, who is an associate professor of neuroscience and genetics at Sheffield Hallam University. Caroline is, as I say, professor of neuroscience at Sheffield Hallam, but she also leads the Living Well with Chronic Disease project at the Advanced Wellbeing Research Centre and the Health and Disease Group in the Biomolecular Science Research Centre. She's an associate editor for Neuroscience Letters and lectures on neurobiology, biochemistry, immunology, and nutrition. And she's been working with long COVID support as an advisor since 2020. We also have world expert, as Benita, I think it was, or perhaps it was Ray, said earlier, Rezia Pretorius, who's the head of psychological sciences department at Stellenbosch University in South Africa. Professor Rezia is a distinguished research professor, director of biocode technologies, developing detection of early stages of disease, and she's an expert in blood coagulation, circulatory inflammatory markers, and how these play a role in the disease. So thank you both for joining the panel. I'll ask the questions, and then feel free to come in. I might go to one or other of you first if it's very obvious. But actually, I wonder if we might start with just a bit of an overview of, where is the research right now? What are the most promising trials that we're seeing? And sort of just perhaps a lay of the land of the research landscape. Perhaps could I start with you, Caroline? Perhaps.
Yeah. Sure. Thanks very much for that introduction, Lola. So I'm a laboratory. Yeah, no, that's fine. So I'm a laboratory scientist. So we've been working with long COVID patients since 2020. We started off doing symptom tracking, and now we're doing research looking at some of the biological measures, that some of the tests that Rizia will tell you about that have been developed, some of the measurements that Ray showed. So I'm very aware of time, so I'm going to do a really whistle-stop tour to answer your question. So there were two main funding calls that were government-funded research for long COVID research in the UK that awarded 19 studies grants in spring 2021. So that was about £38 million, so a significant investment. And those studies mostly looked at things like the epidemiology of long COVID, working out who gets long COVID, which the answer is anybody, and lots of previously fit and well people, what the symptoms look like, how to measure the symptoms, how to track the symptoms, which is what we were involved with, what the long COVID clinics should do, how to evaluate the long COVID clinics, to evaluate the effectiveness of the rehab that we've described, which we've established works for some people, but there's a significant and probably a majority of people that isn't sufficient. It's just supporting them with their symptom management, but doesn't address the underlying pathology. Lots of the studies emphasised online support and apps and kind of patient self-management. So all of that was quite reasonable at that time, because to get a grip on stuff, you kind of need to know what you're dealing with. So that was fine. There were also several studies that were funded looking at biological mechanisms and biomarkers. So a lot of the results that Ray presented as some of the outcomes of that investment in that research. So that's good. So looking at markers of immune system activation, for example. So only one of those studies explicitly looked at a clinical trial of pharmaceutical intervention, which is a trial called Stimulate ICP. So Stimulate ICP, and in a way that was understandable, because you need to know what you're trying to measure. So it's no use trying to give someone a treatment if you don't have the outcome measures agreed. So that was, perfectly reasonable. So these, all these studies have shown what Ray summarised for you very well, that we've got a whole systems condition, particularly inflammation, dysregulation of the immune system, dysregulation of blood vessels, all that endothelial damage that Ray described. So that's all come out of that. And we know that lots of people don't get better just with rehab. So we've got lots and lots and lots of information about how to manage long COVID, but we've got less information about the pharmaceutical treatments, because there's only been this one trial that's been funded. So that trial is what's called a platform trial. So you try different therapies against each other, measure them against no treatment and then each other. So it's testing apixaban, which is an anti-inflammatory, it's testing antihistamines, it's testing apixaban is an anticoagulant, colchicine, which is an anti-inflammatory, and antihistamines. That was, if I was designing that study in late 2020, which was when it was designed, that's probably what I would have chosen to. I think that's fine. It's just we know so much more now, and we have so many more candidate molecules, candidate drugs that we could possibly try now. So and also we don't know whether actually it would be more effective to combine them and not just take them in isolation. So okay, what else? Oh yeah, there's a trial. So that's the only trial, to my knowledge, that has been government funded, and it will be reporting soon. There's a trial by a company called Axella, who looked at an amino acid supplement that's reported, and they found it helped with fatigue. But as far as I know, that's not been rolled out to clinics. There's a couple of trials in the pipeline. So one looking at antivirals, one looking at targeting the vascular system, we're involved in a probiotic trial. None of these have been funded by government funding. They've all been either charity funding or commercial funding. So I think to answer the part of the question about diverse range of symptoms and affected organ systems, I think Ray and Benita explained it really clearly, that you've got a kind of whole systems thing going on here, and that if you just pick off the kind of symptoms on their own, you really aren't going to get to the bottom of it. But actually, if you address the immunological dysfunction or the endothelial dysfunction, you're very likely to actually have a really major impact on lots of symptoms, because they're all related, and it's like a pyramid, and if you deal with the top of the pyramid. So for example, lots of people with long COVID get migraines, so we could focus on, let's find a therapy for long COVID migraines, but actually the migraines are probably caused by neuroinflammation, so sorting out the inflammation would probably be a much more effective strategy. So to summarize for this question, we know lots about what's going wrong in the bodies with people with long COVID, and we've got good ideas about possible hypotheses of how to fix it, but it's all taking too long. And we're getting to the stage where we really need to work out how we can fast track repurposing drugs or possibly supplements to work out which ones work. And I think the problem is, and the thing we've got to solve, is that the way UK science works is, we get together with a group of people and somebody else gets a group with another people, and we think, oh, this drug might work, and we design a trial for that drug, and then some other people over there design a trial for another drug, and everybody kind of does their thing. And really what we need to do is get everybody together and just say, let's make a whole list of all the drugs. Let's agree some core outcome measures, because we've found, we know that's what the other trials, the other studies that were funded have established. So we know, the phenotypes are different. I mean, not everyone will agree how much we know this, but, we've made a lot of progress. We just need to have a list of drugs and just say, bosh, 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 we're going to involve every long COVID clinic in the country, all the patients are really desperate to take part, and do it as a kind of really coordinated, effective push. So
thank you, Caroline. Rizio, have you got anything to add?
I totally agree with what Caroline said, and I think both Ray and Benita I think said quite enough about the dire state of diagnosis and treatment in not only the UK, but also globally. And I think what Caroline said is absolutely fundamental. We need to integrate long COVID research and by looking at the various organ systems that's involved, and by targeting specifically endothelial and thrombotic pathologies that so many researchers have alluded to. And I think the important thing is targeted diagnosis, which can be challenging, and just a global event to try to figure out, perhaps a conference, to sit around the table, to have all the role players around the table, and to discuss how we're going to plan treatment and clinical trials.
Thank you, Rizia. Yeah, that answers my next follow-up, which is, what's the role of politicians in this? Because it's, there's a lot of people who seem to know what needs to happen. So that sounds like a very useful recommendation that we can bring forward. Ray, have you got anything to add to this one?
I agree with absolutely everything Rizia and Caroline have just said, completely agree with it. The main issue for us is, there's two main issues. We can probably come on to that on question 3, but one is funding.
Yeah.
We do not have enough funding to do this, and that's why the research is stalled. And 2, the research is not being prioritised, and there are huge delays in the UK due to inadequate resources, and a lot of that's to do with the MRHA as well.
Okay, yeah. So if we can deep dive at some point in the questions to who we should be targeting as a group to write to lobby, that would be fantastic. But we'll cover that in subsequent questions. Caroline Lucas.
Thanks, Leila. I just wanted to ask a question about data, really, and whether or not you could say a little bit more, Caroline, maybe on how we develop the kind of robust data systems that we need to capture something that is so complex and so comprehensive and so vast, really.
Do you know what? I didn't laugh because it's not funny, but I found this question very ironic. So the implication in the question is that developing a robust data system is an inherently good thing, and that once we've developed a data system, we should keep using it. And of course, the irony is that we had a world-leading data system to track COVID, and of course, in order to track long COVID, you need to know you've had COVID. So, and we've dismantled it. So, so how are we supposed to be able to track long COVID when we have the general messages that people don't need to bother to test anymore? We've just stopped testing in hospitals even, so people will test in hospitals if there's a clinical need, but there's stop the routine testing. We've dropped some of the surveillance, or almost all the surveillance surveys. So you've got a whole load of people who are having a nasty flu, a nasty cold, who may have COVID, but they don't see any need to test. I have even colleagues who say, oh, I just feel terrible, I can't come into work, so I feel terrible. I say, have you tested for COVID? They're like, oh well, there's no point anymore, is there? So how can we test, how can we track long COVID and people even know that they've had long COVID? And that's got really, really important implications. It's got important implications for our research, because when you can't reliably say someone's definitely had COVID because the antibodies drop off and not everybody tests positive on the antibodies. But it also has implications for if they need to claim disability payments and demonstrate that they've definitely had COVID and therefore they definitely have long COVID. So I would say that the data systems and the data we have sort of during, I would say from late 2020 into 21 and most of 22 is actually quite good. And we know, there's been lots of analysis of data about long COVID and how many people have had it, and what the like Ray's talked about, how and Benita, how many, what your likelihood is of getting long COVID if you get COVID, and all of that kind of thing, and all of it's been stripped away now. So yes, so are we in a position to develop it? And no, well, we did develop it, and now we've decided that we don't want it anymore.
Have other countries done the same, just out of interest?
I'm not a big expert on that, but I certainly the countries that are kind of like we're all bored of COVID, aren't we? So the countries that have decided as a policy that they want to pretend it doesn't exist anymore have all followed us, and then there's other countries that definitely haven't. I think we're probably one of the leaders in deciding to dismantle it.
Sure, we are world leading
in dismantling it. Yeah. But that's not my other countries' data is not my area of expertise, so I'm not sure.
Did Ray or Horacio wanted to add anything on the issue of data at this point?
I can perhaps just say from a global perspective, from South Africa in particular, in Africa, there has been no real effort to track and record long COVID. And if we just think about the size of Africa and the number of patients that had acute COVID, it's a global crisis, not only a UK crisis.
Thank you. Back to you, Leila.
Thank you very, very much. And in terms of data in the UK, are we still tracking that data? Are we, other than the ONS data that you're aware of, do you guys have different prevalence data that we should be considering? And in question 3, we also wanted to explore what Ray started to explore about the funding, how it's administered, how much there is, how much do we think we need, and who is it that we should be asking for unblocking. So if you could perhaps start with those 2 little nuggets. Ray, do you want to pick up where you had left off?
To talk about the funding. So I'm just going to lead on from some of the things that Caroline's been saying. So the government has invested 50 million. The last, and that was done through 2 dedicated funding research calls, but the last one was in 2021. And the majority of this was on 19 projects. And Caroline sort of laid that out already. The projects were, one was immunology, one was vaccines, one was economic evaluation, one was health service research, 3 looking at biological causes, 3 looking at diagnoses, 3 were observational, 3 were rehab, 4 were looking at potential treatments, but actually only one out of the whole of the UK, given that we have 2 million people disabled by this condition, is looking at drug treatments in a platform trial. Mm-hmm. And even that project, that's been run by one of my cardiology colleagues in London, Professor Ami Banerjee. And if we have time at the end, which we may not do, he's actually given a statement to talk about some of the issues, even with that one project, that have been going on in the UK. And it would be quite interesting to hear his words if we have time at the end. I've got that statement from him. But and perhaps that isn't surprising, because 2 years ago it was important that we did observational studies. It was important that we did epidemiological studies, and it was important that we did biomechanistic studies, because we didn't know what we're dealing with. We had to learn what we were dealing with very quickly before we could learn how to treat it. We know so much more now, and as part of our international research collaborative that we are involved in, we have a list of multiple drugs that could target different parts of the pathways that may be helpful. So we already know the drugs, and a lot of them are already licensed and being used repurposed, that could be helpful to treat long COVID, but we haven't got the answers yet. And the reason we haven't got the answers is because we haven't got the funding to do the trials, the treatment trials. But also, when you're doing a treatment trial, the regulatory approvals are much more different compared to biomechanistic studies. Any trial that's a CTIM, a trial of clinical trial of investigational medicinal products, has got to go through the MHRA, mm-hmm. And they have to regulate it, make sure it's safe, as well as through a regional ethics committee. And at the moment, the MHRA have got a 6-month backlog before they'll even look at protocol amendments. So already there's a big delay even in the processing. So, and the other thing is the funding. We haven't got any funding from government at the moment in the UK for treatment trials. So Caroline has managed to get some work funded. She's had to do that through external sources. My research group in Newcastle, we have now received funding for a treatment trial, a CTIM trial, but we've had to get that through a charitable foundation. We're in the process of finalising another grant to actually look at some research in children, because we know children are getting affected with long COVID now as well. Yeah. But again, we've had to go through a charitable foundation to get that money, because it's not been forthcoming from government. And we are very grateful to the government for investing initially in the biomechanistics and the observational studies. But now that we've got those results, we have to build on the research we already have. Part of the issue that we haven't done it yet is because long COVID research is no longer being prioritised. And the economic consequences we've already touched on of untreated long COVID in the UK and globally is going to be catastrophic, not just for our generation, but for the next generation and for decades to come, because the post-COVID condition is not just long COVID. There's an increased risk of cardiovascular disease. There may be an increased risk of dementia. There may be an increased risk of Parkinson's. There's a lot we still don't know, but we're beginning to get signals. And so really, some of these pathways pathophysiologically are the same. So treating, for example, the blood vessel issues with long COVID may also reduce the future incidence of heart complications as well. So actually, it's very worth investing in. So the MHRA, for people that don't know what that is, that's the Medicines and Healthcare Products Regulatory Agency, and it's responsible for regulating medicines, medical devices, blood products in the United Kingdom. And obviously, when you're applying to test new drugs in a clinical trial or test already licensed drugs, but you're doing that for a different indication to the licensing approval, you have to get approval from the MHRA. So what really we would like to see is that the MHRA is being appropriately supported by government and appropriately resourced so that they can process their clinical trials applications in a timely manner, because at the moment there's a huge backlog. And we would also really like to ask government to support intervention and to prioritise and fast-track long COVID research in the same way that it did with acute COVID research. And that was phenomenally successful. Panoramic, the COVID recovery trial. I mean, they were getting these trials up and running within weeks. And they were going through all that, we weren't skipping any steps, they were completely safe, they were going through all the regulatory approvals, but all the stops were pulled out, and it was possible. So we know that we can do it. And we feel that we need to have the same level of urgency with long COVID. So why should long COVID research be prioritised over other research? All research is important, but the reason we think it should be is because of the sheer number of individuals it's disabling. 1.9 million in the UK, 145 million worldwide, and 2, because of the sheer number it's going to continue to disable as long as we have high levels of circulating virus, and 3, because of the WHO predictions that if we don't find a treatment, hundreds of millions are going to require longer term care because they will be disabled and unable to function. 4, because of the economic consequences of allowing young adults, who are a significant proportion of our current workforce, and children, who are a significant proportion of our future workforce, to remain disabled without treatment. 5, because with many other diseases, we already have effective treatments, and the research is focused on improving those treatments. With long COVID, we don't have effective treatments yet. None. We've got treatments that can treat symptoms, we've got treatments that can treat subgroups like POTS and MCAS, but we haven't got treatments that will treat the underlying pathophysiology yet, although we have got a lot of drugs we think will help, but we need to make sure that they are safe and effective before we can roll them out across the NHS.
Thank you. Thank you. Can I ask Rizia, is at the international level, is this marrying what we're seeing elsewhere as well? And is this what the coordinating conference would try and iron out? I just want to understand from the slightly bigger picture than what's happening in the UK.
Absolutely. Everything that Ray has mentioned and Caroline has mentioned is not a UK problem. It's not endemic to the UK. It's a dilemma everywhere. I think our US colleagues have been noting the exact same issues. Funding problems severely restrict research and developing novel treatment options, as well as diagnostic methodologies. And that is where we have a fundamental problem in this disease. I think if it was a disease that we could simply ask the patient to go to the nearest pathology laboratory to do a set of blood tests to identify them as being long COVID, and not only rely on clinicians to follow a clinician-based diagnosis. If we had blood biomarkers that is freely available, and I'm saying that because we know that if patients go to their general pathology laboratories and hematology tests are done, they all come back within the normal ranges. And there are certain reasons for that, and I'm not going to go into much detail about that, but Ray mentioned, and Benita in the previous session, mentioned that some of these individuals that we have been testing, or mostly, I must correct myself, most of the individuals with correctly identified as having long COVID has got significant clotting pathologies, and entrapped in all of these clots are all the inflammatory molecules that we will be typically searching for when we do a general pathology lab test. But because they are entrapped, we're not seeing a diagnosis. So the issue is we need really a effort from government to put barrel loads of funding to research, well-known research laboratories that are busy looking at how clotting pathology, endothelial damage, viral persistence, widespread damage to organ systems are playing into this disease, and it's simply not happening, not only in the UK, but I think globally. And therefore, we are indebted to numerous of groups of patients who give funding via crowdfunding initiatives, and that has been helping immensely for research labs like myself. We would have rather wanted funding from governments via a funding system, but it's simply not there. And totally agree with Ray and Caroline on that specific point.
Thank you. I'm going to perhaps move to the next question and ask you to start answering that, which is, and Caroline, then I might come back to you for the questions around children, if that's okay. Because some of the challenges is not just funding. So I wondered if in your subsequent questions you could just expand a little bit. What are the other challenges that we're seeing? And I also wanted to throw in a question I wondered if anyone could answer. So recently, I think it was last week, the WHO came out and said that COVID was no longer a global health emergency. I wondered if you could posit what impact that's going to have on this space, and if you've seen, any change or you have any concerns about that as well. Ray, you had your hand up, so any of those you could answer, that would be great.
Yeah, so I think if we actually listen to what Dr. Tedros said, he said it was being downgraded from a global health emergency to a global health threat, meaning it was becoming endemic. What he didn't mean was that it had gone away. And for some reason, the media have picked this up as the pandemic's over, COVID's over, we don't need to worry about it anymore. That is simply not true. COVID is not over. We all want it to be, and I wish it was, but nobody gave the virus the memo, and the virus is still killing, it's still maiming, and it's still disabling. And, if we look at it compared to car crashes in the road, if we had a situation globally where 7 million people had died in 3 years on our roads and 145 million had been disabled, including millions of children, there would be an international outrage. What level of death and disability is it going to take for us to take this seriously? And I think Dr. Tedros' words have been a little bit misconstrued. I think what was trying to be said was that it's now becoming endemic. We now have to move on and actually learn to live with it safely. We're downgrading the threat because it's not unexpected anymore. It's still there, but it's not unexpected. But that has been misinterpreted, and already we're seeing people saying, well, there's no need to test because COVID's over, there's no need to mask, there's no need to do this, there's no need to do that. And we're in the middle of another COVID wave at the moment. We now know that we've got XBB 1.16 in the UK. We know it's causing conjunctivitis. We know it's got a predilection for children. And I've hardly heard anything about it on the news at all. And people don't realise this. I've even had a relative of mine who caught it and posted a picture of her horrific eyes, couldn't see, didn't know what was going on, really scared, saying, I don't know why this has happened. And I said, you've got COVID. She said, what makes you think that? And I said, because this is XBB1, and I told her all the symptoms. She went, and then 2 days later, she's like, oh, I've lost my sense of taste and smell as well, and I feel dreadful. And she did have COVID, but if the public aren't being told, then they're not going to know. And I've heard so many people talking, saying, oh, I've just got this cold that I just can't shake, and I can't get out of bed, and I don't know what's wrong with me. Have you tested? No. What COVID precautions are you taking? You've had it 3 times now. You've got worse each time. Oh, nothing. Have you thought about wearing a mask if you have to go to an indoor crowded place? No. And what are we doing for our kids in schools? There's now published research, 2 papers in the last few weeks. One demonstrating that actually schools are a major zone of transmission. The other one looking at Omicron, showing that actually children are getting quite a lot of long COVID with Omicron. That's Seamus Ladhani has just published a preprint. 12% of children on a first infection with Omicron developing long COVID, 16% on a reinfection. That is not insignificant. And if you add into that with the kids, there are now 3 papers coming out, very small, and obviously they need to be validated, but looking at children that didn't have long COVID, that have been infected, it was a mild index infection and fully recovered. And there's 3 papers suggesting that they may have subclinical organ damage in their hearts and their lungs, as well as an increased incidence of diabetes. So this itself is, concerning, because we don't know what silent damage is being done under the surface. And we really need to be researching this and looking at it. And I think the misconstrued statement by Dr. Tedros is not helping. Thank you.
Yeah, and I would tend to agree. It's certainly the mood we've had in Parliament as well. It's I think not everyone read the whole thing, which is perhaps not unusual. And to the point around recruiting people into the trials and that sort of thing, Caroline, do you want to maybe talk?
Yeah. So recruiting people are desperate, absolutely desperate to take part in trials. So we advertised just locally for a pilot study. We were looking for 30 people. We got 300 volunteers in less than 48 hours, fewer than 48 hours. So as a result of being on this today, think my email box will just explode with people saying, oh, I heard you were doing stuff, please I get on your list to volunteer. So that's not an issue. There is an issue of making sure that the people we recruit into trials are representative across the full population and a diverse population. We know women are more likely to apply for trials. We know or apply for research studies. We know that people who are middle class are more likely to do it. We know people who are white are more likely to do it. So we need to make sure that we recruit diversely, and we're working with our local community organisations to ensure that happens. Yeah. There's also challenges with timing of treatment. So as Ray and Benita set out, the people we really want to recruit from long COVID clinics, because those people have had a workup, they've had a clinician, or at least, you know, people have discussed with them and registered them as having long COVID rather than self-identifying. But then they've had long COVID for 3 months, then they've been to the GP, then there's been a delay, now they're at the clinic, then there's a delay, and they're a year, 2 years, 3 years into it, and there's some evidence that the sooner you treat, the bigger impact you could have. But of course, the people who've had long COVID for longer are the ones that have had more of a burden, if you like, so we should definitely treat those as well. But there's when you treat and the timing of treating, and if you only recruit from long COVID clinics, do you miss that opportunity for an early intervention, are issues as well. But you know, we could round up, I have a whole mailing list of people volunteering. We could round up thousands of people who are desperate to take part. So recruitment is not an issue.
Okay, that's unsurprising perhaps. Could I perhaps, and Rezi, if there's anything urgent you want to add to this round, please go ahead. Otherwise I'll throw it to Caroline. Is there anything you want to say at this point?
No, I totally agree with Caroline. We also have seen thousands of people emailing and coming to our research lab to have our tests done in our research lab for diagnosis of microclots and platelet hyperactivation for thrombotic endothelitis. And it's just horrific to see the amount of very sick individuals with no options.
Yeah, same here. Yeah.
Caroline.
I just wanted to come back to children. We've touched on it several times just recently, but are there particular challenges of diagnosing and treating long COVID in children? And is there specific research that needs to be commissioned to address those challenges?
So the answer to that is yes and yes. And what I thought I would do is, I think it's important to point out that none of us on the research panel today are paediatricians. I am, however, a medical champion for the Long COVID Kids charity, and I'm actually currently working with some really good paediatricians, both in the UK and overseas, to try and get some long COVID research in children's up and running. So I've been tasked with answering this question, but what I thought it was better to do, if you don't mind, is I actually think this question is best answered by a consultant paediatrician that specialises in long COVID. And so what I asked ahead of this meeting is I asked my Italian colleague, who's Dr. Danilo Bonsenzo. He's a consultant paediatric infectious diseases specialist in Rome in Italy, to answer and write a statement for us for this question. Now, the reason I asked him is because he runs an amazing long COVID kids clinic in Italy. It's incredibly comprehensive. He's also leading the way in the very limited children's research that is up and running at the moment. So he's certainly the European leading expert. I would think he's probably one of the world experts. So if it's okay with you, I'm just going to read you what he's written. So this is from Danilo. Initially, the main challenge in diagnosing long COVID was in convincing colleagues, and sometimes parents as well, that an organic event could be the cause of the symptoms the children were complaining of, rather than psychological consequences of social restrictions. Luckily now, everyone seems to agree that long COVID is a real disease, and therefore it is easier to have support from colleagues in other specialty areas to help manage our children with long COVID. The main challenge is that long COVID is a multi-system disease, and as such requires several diagnostic tools to find the abnormal events that can then be pharmacologically treated. And we span in our clinic from easy tests like the 10-minute stand test, which is what I was talking about for dysautonomia, 6-minute walk test, 24-hour ECGs, to more complex tests like brain PET scanning, lung perfusion studies, MRI or SPECT scanning, to research diagnostics like platelet hyperactivation and tests of endothelial function, which we've mentioned already. Therefore, the approach may be expensive as it requires several tests at the moment and consultation with multiple colleagues. It can also be more challenging when done in young people that may not be compliant with some of the tests. We need governments to invest in dedicated centres that put resources into evaluating children with long COVID. And for example, in my setting, I do run a long COVID clinic and I do have colleagues collaborating with me, but they're all busy with their own jobs. And so the waiting list for specialist input may be long. In terms of research, in my opinion, we need much more funding into the aforementioned diagnostics, and we need to be able to detect abnormal findings in children with long COVID. We need to stop spending money on online surveys that have zero value, but invest this money instead in looking for biomarkers in children with persisting symptoms, and invest in trying to treat the very severe burden of disease that we can see in our children. In adults, we already have several studies ongoing at this point. In children, in Rome, I am doing proteomic and IMRA studies, and I am finding already impressive differences. However, the funds are small, and because of that, we can only go slowly. These diagnostics are necessary to help eventually develop a diagnostic blood test for children to help diagnose long COVID. We need pharmacological trials. Unfortunately, we cannot keep waiting on this until we have better knowledge of the pathogenesis. Patients and children are suffering. Ivabradine versus placebo for children in long COVID with the POTS phenotype, for example, a trial looking at gabapentin for severe intractable headaches in children that may be bedbound, a trial of anticoagulants and antiplatelets for children with severe systemic symptoms with microclotting and endothelial pathology. These are children that are barely able to walk. Trials of nutricals and neurocognitive interventions with children with cognitive dysfunction and memory issues as a result of COVID. Antivirals could also be trialled in children, although I think it would make more sense to have them trialled at the time of infection rather than months down the line. That's from Danilo. And what I would like to add from a UK perspective is, this is one of the doctors that is leading the way already. He already is doing a lot more tests in his children in Italy than we are doing in the UK. So we have a real paucity of there are some long COVID children's clinics, but there's not that many. And certainly what I am hearing from the parents through the work I'm doing with long COVID kids is a lot of them are really struggling to access help and support for their children and diagnosis. Some of them can't even get the diagnosis. And there are still some individual parents who are finding that, you know, they go and they try and get help and they get the routine blood tests and they're told they're normal and that probably their child's just anxious or depressed or there's something else going on. And these children are really struggling for help and support.
Thank you very much. That's really, really clear. Thank you. Back to you, Leila.
Thank you very much, all. So the next one's about, and I'm sorry we're running slightly over, but we're very nearly there. With your permission, if I can ask the last two questions briefly. Perhaps I'll ask Caroline and Rezia to focus on the next one, which is the integration of long COVID research into current health systems. Have you got recommendations that you'd like us to push forward? Perhaps I can start with Caroline on this one, and then go
I think
the other way around.
Yeah.
Rezia.
Yeah, sure. Definitely, we need to integrate long COVID research into existing healthcare systems. And this is not only possible, but it is essential. And the reason why it's essential, we need it to effectively address the need of patients experiencing long COVID. So by incorporating research findings and also possibly formulating guidelines from research findings into primary care, specialist clinics, hospital-based care, and healthcare providers' environments, we can better diagnose, treat, and manage long COVID cases. I wish to point out 4 steps to achieve the integration and awareness of research into our existing symptoms. And I know we've time restricted. I'll try to be brief. My first point is we need education and training for our healthcare professionals at all levels. We need to ensure that healthcare professionals, including primary care physicians and specialists, etc., are aware of the latest research findings and of the guidelines that are currently there, and it might not be the ideal guidelines related to long COVID treatment. This includes also the understanding of the varied symptoms, the potential risk factors, and also to encourage these healthcare providers and physicians to read latest research where novel diagnostic approaches have been found to be effective to diagnose patients, including those with cardiovascular damage as well as clotting pathologies. My second point is that we need clear clinical guidelines. We need to develop and implement evidence-based clinical guidelines based on prevailing hypotheses that where treatments were found to be effective might help healthcare providers to identify, diagnose, and manage long COVID patients in the various different care settings. My third point is that we need a multidisciplinary approach and patient-centered care where we encourage a collaborative, multidisciplinary approach to care of patients with long COVID, as the condition also involves, as we heard now multiple times during this discussion, a complex interplay of multiple organ systems being affected. We do not only suggest a rehabilitation focus, but also a focus on using a variety of various physiological markers, including perhaps novel blood markers, and even using novel diagnostic equipment that we find in research labs. Then my last point, and this is quite important, I think, is that we need to integrate research into existing healthcare systems by publishing clinician-initiated treatment regimes in the absence of clinical trial data. And we need to find options to see where these clinician-initiated treatment regimes have provided effective treatment options in the current absence of clinical trial data. And the way to go about this probably currently without clinical trials is a series of case studies. By integrating long COVID research into our existing healthcare systems, healthcare providers can better identify, diagnose, and manage this very complex condition. And the idea would be, I think, the takeaway from here is we ultimately need to provide patients with outcomes that they can have quality of life, which they are not at the moment having.
Leila, I think I'd add to that we're looking in my lab for biomarkers. I'm a big fan of biomarkers, but I think we shouldn't get too sidetracked by needing a biomarker, expecting to find a biomarker that everybody in long COVID who has long COVID is going to have one biomarker and nobody, the controls, are going to have it, because it's a heterogeneous condition. There'll be some subgroups that have one marker, and it's likely to be a group of biomarkers together. So I think this is used as an excuse, like, well, until we have a biomarker, how can we know, how can we start treatment? And I just think that's a red herring. I think that clinicians who are experienced with working with people with long COVID, and healthcare professionals know long COVID when they see it, from the patient history, the choppy recovery, the crashes when they on exertion, the post-exertional symptom exacerbation, and then alongside that, these tests we've been talking about. And it's that constellation that provides the diagnosis. And this to wait until there's some magic mystery molecule that we haven't tagged yet with it is not the point. So I'd just like to add that.
Thank you, that's really helpful. Paul, last question.
Well, there's been a consistent theme through this entire session, which has been emphasised in the last half hour, that the UK government and a lot of other governments are just looking the other way and wishing this problem would go away. Yeah. So my final question to the two UK-based panelists is, what would be your top recommendations to the UK government that would make a big difference? And Razia, could you tell us, are there any countries in the world that are doing perhaps not a perfect job, but a better job of this? Shall I start with Ray?
Thank you. So from a research perspective, obviously Benita and I have kind of summarised what we think on a larger global scale needs to be done to tackle long COVID, but purely from a research perspective, what we would like and what we would recommend to our UK government is we would like a third funding call from government for long COVID treatment trials, specifically pharmacological drug therapy trials, and a push for those to include children's trials, biomechanistic and treatment trials in children. 2, we would like the government to support and fast track and prioritise long COVID research in exactly the same way we successfully fast tracked acute COVID research. 3, we would like to see significant improvements in the expediency of the current CTIMP, that's the clinical trial of investigational medicinal product trial pathways. And we would like to see the MHRA to be adequately supported and resourced to enable a more rapid turnaround of trial approvals. Long COVID is a mass disabling event on an unprecedented global scale. And what we need is we need our government's support to prevent millions more UK citizens, including children, from developing long COVID due to repeated SARS-CoV-2 infections, which they are constantly exposed to. And 2, to enable us to quickly find effective treatments, both to prevent people who've been infected developing long COVID, but also to treat the millions already suffering from this very disabling physical disease. Our patients have already been waiting far too long for effective help.
Thank you. And Caroline?
So I totally agree with everything Ray said. I'd just like to add to that the idea of some sort of task force, because the trouble, and I totally agree that the government should have another call, as Ray's described, but that's going to be much less effective if all the different groups all come up with their own kind of versions and their own drug that they're keen on, and everybody competes against each other, and then they fund 3 of them, and these over here might not be, so we have the UKRI have task force or coordination groups for other conditions like Parkinson's, certainly, if not currently, they certainly have at various points. So I think there should be some sort of task force that decides and coordinates it to make sure that it's the maximum effectiveness.
I couldn't agree more. As I said earlier, we've got a lot of talented people working in this field, and no one's putting it all together.
And people are quite collaborative actually in this field. They're not all at each other's throats. So I think if you pull them all together, they'll all be quite chuffed and happy to do that. And
Razia, who is doing it right?
I don't think anyone is doing it right, Paul. Unfortunately, it's hard to say and a difficult comment to make. But I think we have just dropped the ball. I really think we've dropped the ball. The global research and clinical environment has not done what we're supposed to do to treat and to look at these patients. Perhaps I can just, one more recommendation that I could add, and it was quite interesting for me. There was data out just this morning from the Office of the National Statistics in the UK, and it suggests that unemployment due to long-term sickness is at an all-time high. And I think the report said it is approximately 2.5 million people in the UK alone. So I think, as a key recommendation, there is an urgent need to look at the data to determine which numbers from this national statistics in the UK can be ascribed to long COVID, or then at least clotting-related conditions. We have seen that many patients with long COVID were previously fit and healthy patients before they became patients. So there's definitely an urgent need for the NHS to do risk assessment for long COVID, and perhaps a starting point is the national statistics in the UK.
Well, the UK economy is suffering from a shortage of workforce.
Yeah.
And this must be one of the main reasons.
Yeah,
which is just being ignored.
Yeah.
Okay, back to you, Leila.
Well, thank you, Paul. And I think actually that sort of rounds us to where we began, because we noticed those statistics and also that comment in the report as well. So thank you, Rizzy, for highlighting that. It leaves me simply to say thank you everyone for your amazing answers. We've gone over by 15 minutes, but it hasn't felt that way because it's so rich in what we've heard. So thank you, Rizia, thank you, Caroline, thank you, Ray, and again, thank you to Benita for sparing your time, rearranging your clinics, bearing with us. We will now digest all of this, work out who we can best lobby. You've definitely given us impetus to directions we were already going in, but also given us some new avenues that we clearly need to now push hard on. And to what you said, Rizzy, about dropping the ball, we are determined in this parliament that we don't drop the ball on those who are living with long COVID. We will continue to do whatever we can to help to support those who are living with it, but also thank you to you all for the work you do and the advocacy you personally do. You are clearly very passionate, and you couldn't have better advocates on side as what we've seen today. So thank you all for everything. Thank you everyone for watching, and thank you to Best for Britain for being such able secretariats. We'll now go away and put it all together. Just leaving you to say goodbye. Have a wonderful afternoon, everyone.
Right.
Thank you for having me.